Welcome back, everyone. Thank you for your patience, especially those who are watching us through Zoom and YouTube. Next, we'll hear from Dr. Jimena Olveres Montiel, professor at UNAM's Faculty of Engineering and an expert in generative AI and biomedical image analysis. She will guide us through one of the most crucial steps in computer-aided diagnosis, segmentation in medical images. Please welcome Dr. Jimena Olveres Montiel.
Everyone. Thank you for being here, to those people who are present, and thank you for those who are on the Zoom session. I know it's been hard. It's almost finished, so keep on, keep up with the good work. I'm going to speak about segmentation for medical images, and basically segmentation initially started as a field of computer visions, and it's the process of dividing a digital image into their multiple parts. The goal of this segmentation is to simplify and change the representation of an image, and in order to give it a more meaningful representation. So from this image, maybe I just want to analyze the heart. So in order to do that, I have to apply several algorithms, and the idea is that they will allow me to have a better medical image analysis and enable for example, the detection of the cameras of the heart, or maybe of all of these anatomical structures that will help me to get an accurate diagnosis and treatment planning. So the difference between segmentation, that's something that I always tell my students, is that what you are doing here is compared with classification or location or detection, is that you're going to do a delineation of this and special partitioning of this image into its parts. So we need to do that to support a further analysis. So there are two main tasks when I'm doing a segmentation. One is the recognition of the object. Let me change again back. So I'm going to recognize the cat or the dog or maybe the dog. Here is, if you can see, there's a little dog here. But usually, normally humans are better, no, for what to recognize what was in there, and a delineation. That's to get the object boundaries. So for that, computers are better, are proved to be better. So there are many techniques usually used from image processing and signal processing adapted to these algorithms, and of course there are many clinical needs for this, which has given us a lot of space for those who are studying segmentation techniques. So, for example, here, some of the initial segmentation that were done by the doctors or clinicians, it's like they were scribbling or trying to notice, for example, here some micro classifications, and from there they were trying to decide if it would become a tumor or not, no, or it was only something that was benign. For these image segmentation techniques, well, we need high precision and accuracy with minimal and no human help. Why is that? Because clinicians, they specialize in the diagnosis, planning, and treatment, and post-operatory following. So we need to give them that support that will let them focus on their task. So but usually these are not completely automatic. These algorithms that help are not completely automatic. So we need to have all of these concepts given in a tool for segmentation. And in this way, we can improve our procedures and support new areas for computer-aided aided radiology. So as I said, there's a variety of users, and normally it all depends on the problem. It usually happens that it all depends on the problem that you want to segment, that you want to attack. So maybe in 2D measurements, I'm gonna just try to measure with two axes, two distances here, but maybe I don't want that. I need something more like a 3D volume, calculate the 3D volume and do a measurement for that. There's going to be a different topic if I want another problem, if I want to tackle another problem, like this abdominal aortic aneurysm, and then get the volume. So the idea of this is to give the doctor a view of the problem, so they can do maybe taking from 2D slices of a tomographic image, create a model that can help and give you more insights about what's to be done. So in order to do that, we need validations, validate all these algorithms that are created, and is normally its validation requires a ground truth for comparison, which is very, very, very difficult, because in human organs or human or biomedical organs, or we not normally don't have a ground truth. This is where clinicians help a lot. So we need physical anatomical models or phantoms. Sometimes are available, sometimes not, except maybe for bones, no, which are more available. But ground truth is usually obtained by manual segmentation, no, like doing the delineation of the doctors, of the clinicians, and they help to support this identification of segmentation. Most of the experts not always, but most of the experts in medical images are radiologists. And we want to compare these algorithms with others, no? So as far from what you can see, there's been there are many algorithms that some of them are manual, like what the clinician do. They do a manual delineation, and others are automatic. They segment and partition the image with no human interaction, and semi-automatic, which is a combination. There's a little of support from the human person, like saying, here, this is where I want to segment, no? And they do a scribble of something. And then, well, the idea is that they are not completely, they are automatic or nearly automatic. They don't need that much interaction. This is an example of a manual segmentation, no? Where you can see here, where you can see that there's a tool that helps the clinicians to do their annotation, but they are very valuable. Though let's think, even and they are very valuable because nowadays in the deep learning area, we need a lot of annotations, no, in order to get an algorithm that behaves correctly or near what we are looking for. So the problems is that there's a lot of anatomical variability, yes, and also sometimes the visualization is difficult. They say that this is the same model that I want to get, but the image is coming in this, like this, no? So it's hard to find the correct organ from 2D. So we have to do it also in 3D. Apply these algorithms for that, and also we have to validate them. No, we have to get metrics, like to compare what we are expecting to what we are getting from the algorithm. So in order to do that, we usually use distances, metric distances, where we have a reference. Let's say this is the organ for reference, and this is the result of the algorithm. And there are lots of them, you can see, and find in the area. One of the last ones that has been used a lot, but these are not the only ones. There are more, depending on the problem, that this is area of overlap over area of union. It's called intersection over union. But the idea is to get at least a good metric for that. This says when this is overlapping completely, it's an excellent segmentation, no? Like what the algorithm did to what the clinician segmented. So, and this is a very poor segmentation. We don't want that. And if we do it on the volumes, well, the problem is getting more complicated, no? So these are some of the metrics, but also when we are trying to segment an image, there are pixels or voxels that need to be evaluated and say, this is right and this is wrong. So that's why we use the confusion matrix when it says, I got a pixel that belongs to a tumor, and if it's positive, well, that's one count. The next pixel, let's say, of the image, it wasn't. I said that it was, but it wasn't, so I'm going to count here. So that's a way to measure, no? At least this segmentation. So we're going to have also the false negatives, true positives that come from here. And from there, we can get a lot of other metrics, no? That are evaluated on how much true positives, false negatives, pixels, or voxels I am getting. And some of them are very used, like accuracy, precision, and there are many others. So this is part of what we do in a segmentation. It's not only that it's magically. So we have a lot of algorithms that need to be evaluated, and some of them work better for some organs, and some of them might work better for others. No, it all depends on the on the algorithm, and also as nowadays with deep learning, we need a lot of annotations. This is getting complicated because we want these annotations from clinicians. And the problem is that we have also intra-observer variability. I'm going to show you an example of them. And then a single observer is doing this segmentation, no? But in the morning, when we are awake and just had breakfast, we are very good for doing that. But in the afternoon, after looking many patients and doing a lot of work, maybe our segmentation is not so good, our delineation. So there's variability even for one person, no? And also between multiple observers, no? There's also another variability that some people segment in one way and some others in other. And also it's not the same if I want to have a measurement linearly, or I want to have measure like in volumes, no? In this case, if you see, the change with something that is measured linearly was 4%, and the change in volume was 35%, no? And now imagine this is a tumor, so it's, in some cases, it would be called a progression, or in some cases, it will be called that is stable. So all of these have to be known. This is like, I like it a lot, because there's a delineation, as I said, of 9 independent observers of a tumor in the brain. And look at this. Some of them are very close to the border of the tumor, but some of them prefer to stay a little bit outside, no? Just a little bit. So there's a lot of differences between one observer and another. And there's a study, that says there is a variability of 30%. If it's a tumor, I would like them to be all agree, no? In the same for that. Okay, so, well, this is an issue, no, for that. And that's why it's good to know the ground truth, but it's not usually something that we get. It's good to have a tool that has a ground truth, that is, it can be tackle this inter-observer variability and this inter-observer variability. So the measure is also something that I want to do in multiple measurements of the same organ, for example. And of course, one of the main problems is that all of our images in medical images have different image techniques, no? Like radiography, magnetic resonance, nuclear medicine, ultrasound. Some of them have more noise than others. Some of them have blur edges. So this limits the algorithms that may be working in a computer tomography, but not on an ultrasound, for example, no? And there's the problem is that the quantity of images and techniques is growing. The quantity of images is growing exponentially. There's studies for that, but also these techniques are always also changing, and there are many others that are evolving. So there's no universal segmentation. That's the first part that I want to say here. There's no universal segmentation algorithm because there is a very large number of available algorithms that tackle different problems. So, and they can have many ways of working, but they present different characteristics, and they should be based on the image, the characteristics of the image, like texture, intensity, shape, location of the organ that I want to segment. And that will give us relations with the algorithms that can be used, that could be simple or complex. Okay, so to give an example, there is a list here of some segmentation methods that I am going to speak very briefly, some of them, and because we don't have enough time, as I would like to, but some of them are like thresholding, edge detection, mathematical morphology, regions, deformable model, deep learning, and I'm going to talk also about hybrid models, which have given a lot of good results lately. Okay, so thresholding is like you have a histogram of the image based on their intensities, and then you put a threshold. And from here to the end, you will say all of these, I'm going to give them a number 1, and from here to here, I'm going to give them a 0. So I'm thresholding the image, and instead of having these shadows, let's say, it will give me this. The problem comes later. Like I want to threshold this into the background, the brain tissue, and the skull, no? And from this image, this is an resonance head CT. So if I get these two threshold, can you see it? I create a histogram of the image, and then I apply to threshold, and I get this. Who can tell me what's the problem? What's the problem? I have noise. Some pixels that I thought that they were in the gray levels of brain tissue, for example here, were not, no? Because that's why I have these black dots around here. And also happens, well, here it doesn't happen, but it also happens here in the background, no? I was supposed to get just the outside, but here I have some pixels that say that is background. Yes, can you say that? Then, well, what can I do? Also, also I'm getting the tissue, the brain tissue, but also I'm getting also part of the bone here. So there are other methods that support, that help to create a better segmentation, like morphology operation. And from this method, for example, is a type of filter that is applied to the image, the processed image, and then you can get rid in that way of this part of the skull pixels, no? How does it do it? Because it takes only the largest component, only the largest area that belongs to the brain. And then these are smallest area. This is a small area, so we don't want that. No? That's something that it does. And then there are so others to, for example, here we still have those little dots, black dots. We don't want them, we said that. There's another filter called dilation that gets rid of that. Like that it expands the white area, and then with the erosion, it contracts it again to the same position. And from here, I get a mask, a binary mask, that if I multiply it or overlap it with the original image, I can get this, the final result, and just get the information of the brain, the brain tissue. So there's a lot of examples for this. So I have here with hip bones, no? I want to get the hip bones. So I threshold the image and then I apply some mathematical morphology. And then even with another algorithm, I can get the 3D model from there if I do it on all the tomographic images, 2D images, right? Okay, so of course there's limitation on this, no? Is working only for intensities, for example. If I don't get the threshold correctly, it might not get a good result for that. Okay, some other algorithms is those based on edges. So this is an ideal edge. I want to detect it, but normally the images are not like that. Are something like that is soft. The edges are changing soft. So now all the natural images happen to have that. So we use derivatives and create filters for this, and it can be helpful to do something edge detection like this, the vertebrae, for example, or maybe carpal bones. What I'm getting is the edge, remember. So I'm using a filter of derivatives that comes here, and when it finds a change, then there's the edge. Exactly. Can you see it then? Okay. And it's also happening in all the images, no? So this was very used a long time ago, but it has their problems, no? Also, what problem could it be? Can you tell me, the people here? What do you see? Some filters, some images have noise, no? And some of these filters, depending on the filter used, can make bigger the noise. Can you see it? It's like black and white dots. Can you see that? So if the filter is so good, it can make it worse, no? Make it worse. The outlines of the noise we can get on these edges. So we have to find a way to get this, no? So the idea then is also use pre-processing for the images, like using something that gets rid of the noise initially before using these algorithms. And where there's a lot of other algorithms used. This is, for example, growing regions, where you can see there are 4 different regions, and it all depends on the function that I use, on the criteria that I use to try to resolve these regions. Like, for example, here are 4, but what about this? I could have 5 regions, no? Or if I say this is a region, I could have 6, no? Or something in here. It all depends on my criteria. What do I want to see? One of the very used one is the seed. It's like I set a seed in the image, like here. Sorry, it doesn't. And from there, it starts growing and adding pixels that have a similar criteria. So, the final result would be here. And in this case, if we compare this growing region algorithms compared with thresholding, well, we noticed, we said before that we can have some noise, but in this case, if I use the seeded region, I won't have this noise because it only takes adjacent pixels. The seed will be adding only adjacent pixels of the region. So in the moment that there's a bigger spot here that is black, it says this is not part of the tumor, for example. So and there are many. Obviously, it depends on where I set the seed, no? Initially. So, and this is something semi-automatic. Remember that I said that there are some algorithms that are semi-automatic or nearly automatic. And here we need a person that says, this is what I'm looking for, and there's where the seed is placed, right? So this algorithm rely on initial seeds, as I said. I'm gonna go fast, but what happens when there's texture? Here, I'm adding an image with texture, different texture, but what I want to do is get a segmentation. Which images have lot of textures, like ultrasound, no? They have a lot of textures that could be used. So it can be hard for them, for edges to do that. Or something like region segmentation needs a more complex criteria for that, okay? There's also the formable models. We are almost finished and getting to deep learning. Okay, the formable models, the idea is to start with a boundary close to the structure. Let's say that I have an elastic cord, and I have the structures, and I'm going to span the elastic cord a lot. So in that way that it will surround or be outside. So with this deformable contour, it will, if I release it, it will start to go into the borders or the edges of the image, no? In order to get this. So these deformable contours find a shape in a way that takes in account external and internal forces of the image. And it usually takes advantages of also these borders or derivative. And these deformable models can have, for example, this is a kidney, and a model of a kidney, a 3D kidney taken from CT image. And then I add a deformable model. Let's say now it's 3D, it's a balloon. It's not an elastic cord, it's a balloon. So the balloon, I add air until it goes outside of here, and then I release the air, no? That's what I do. I release the air, and then it will go into the shape that I'm taking. So we can have a prior shape, or we can have a weak prior shape, like it's totally wrong. Weak, strong shape is if I know, for example, the kidney, it has a shape of a bean, no? Something similar to a bean. So I could use it for that. And also, if I want to tackle this problem of how the heart is moving, I also can use these deformable models, no, in order to find how the edges, how the borders of the images are moving in time. So the problem can be something like this when I'm using these deformable models is that they don't get completely to the border or to the edges. Can you see that, the problem? So it all depends on the function of, here we are talking about optimization. There's an optimization function in there. So it can be hard. And at last is active shape models that they have they search for a specific form, and a specific shape, and and usually we can have a similar shapes, like for example, here I have the midbrain on these magnetic resonance images, and where I'm gonna get is the shape of the midbrain here. If I do it in all the CT images, all the tomographic images, I can get a volume, no? A volume representation on this. And the idea of the active shape models is that these organs have a specific shape. Like here you could see something like a butterfly, no? So I add that information to the algorithm in previously. Well, we're going to go there now to the deep learning methods, where especially UNet and its variants have become the standard for medical images. But before going into the UNet, we have to say that these models are capable of learning very intricate features, but they need large data sets. Large data sets, and what else? We need a lot of data sets, and what else? A good hardware, no? Like GPUs, the use of GPUs in order to make it faster also. Because as I am processing lots of images and doing lots of operations, they need very good, then they also need a hardware for that. So that's why they have more accurate and robust segmentation results, but it has a cost. See, it's like the no free lunch axiom, no? Everything has a cost at the end. And from here we can know, we started with basic convolutional networks, where we can see that we extract the features from all of these convolutions. There are convolutions in here with multiple filters that give us on every stage of the network, they will give us different characteristics and features of the image, until we get something that is a small data, and from there we can already apply classification part of the pixel, for example, no? And this convolutional, well, the images, the more images you provide, the better the final results, no? They are very widely used models for this, and they have shown very good results in general, no? Like, for example, here we were doing a segmentation of cerebellum in fetuses, like using ultrasound images, and you can see it here. Here is the cerebellum, and this is the mask, binary mask provided by the clinician. So here, it's not only that we have a lot of data set of images, but also annotation, because this is a supervised, it's called a supervised technique, because we need a lot of annotation from the clinicians that support what the result is expected from these CNNs. Well, we got very good results, and also, as you can see, we have to measure also again, no, do the metrics for these results, no, compare them with what the predicted class was and what the true class was, no, we compare all of this. And one of the after using the CNS, then it came in 2015, the unit by Ronenberg and et al. And this I really like this network, because it has lots of concept of vision computing. Like it has it's a classic convolutional network, but it has also it has an encoder decoder part, where you can get with something very short, and then getting again, going back again to the image, but it will be already segmented here. However, any improvements have been done in this unit, a lot of improvements. We've been using it at first, we use it to segment the heart in ultrasound images, which are very noisy, as everyone knows, but we got very good results from that. And but again, the tackle is, the problem is that we need a lot of images, we need a lot of annotations, and from there we can get good results. Also, there's something that is called interactive medical image segmentation. In order to make this that doesn't take that much time to the network, well, we can get some interaction of the doctors, like getting a result, a previous result, and the doctor says, yes, it's going well, or no, this is not what I expected, and this is what I wanted. So there's a semi-automatic algorithm, and it has given also very good results. And also the hybrid methods, no? Like, with all the methods that I told you before, I can use maybe first a unit in this image to get the location, where is the organ that I'm looking for, like here the ventricle and the atria, and then from there take it to a level set, for example, no, a deformable model, and it will take less images for training, and it will take less time also for that. And from here, I can do, as I said, a lot of analysis after that, like maybe getting some parameters, or even maybe getting some idea or calculating the optical flux of the heart, no? Here. So that's something that is hybrid, no? And also there's, as we said, also there are other problems in, for example, using this YOLO, no? That we want to use for detection and classification of skin lesions. Well, we didn't have, in that time, the first time that I used it, we didn't have that many images of these melanomas examples. But what we did is, in order to get more augmentation, is to use these images and use their segmentations, no? By different means, different algorithms of classical segmentation. And in that way, we got more images also. No, not only the usual ones that is translation, rotation, stuff like that, but also adding more information by getting segmented images also for the training phase. In order to get more data set, a bigger data set. And that gave us better results for that in that time. And also when there's all nowadays is the emerging architectures, no? Like the vision transformers is what everyone is talking about with generative AI. But the idea is that instead of getting the whole image, we have a lot of image again, we need a lot of images, but instead of getting the whole image, we will gonna break it in patches, and treating each patch as a different thing that we're gonna process, and then the transformer will take care of obtaining and embedding of these images that I'm using. And it has given very good results. And also there's been use of like combining the transformer with the unit, no? For example, in order to get this image of the heart and get a segmentation mask from here. So what I'm trying to say is that every day new architectures are created and they have good results. So it's something that is evolving. Every day it's evolving, the segmentation area, and there's lots of opportunities to work in this place again, no? Some of them need more images, and also this deep learning is also used to create more images, like for example, the style transfer network, that we can get a style of an image to create more images. This can be used for medical, but also there's one network that we've been using lately that is the segformer. It's a transformer for segmentation, of course, and it's very widely used all over the world. So we gave it we gave it a try, and it gave us very good results, like trying to segment this heart, the ultrasound, in different views, no? The 4-chamber and this in this other view. So what I'm trying to say is that the idea of this segmentation is to give the space for further analysis and to help and support the, clinicians later on their work, no, on their task, and give them something that they can understand better, for example. And well, also for data augmentation lately is the generation of medical images with diffusion models, no? One of the things that we have problems is we need a large number of images, but also most of them we need balanced to balance the images. Some have anomalies, some are normal, and they have to be balanced, the same quantity for each of them in order to make work these architectures. So we've been using also then these diffusion models in the lab in order to compensate this lack of data, no, for the medical area. And it has worked up to some extent also. And well, there are lots of challenges, as I said, no? We need data, we need annotations from the clinicians, we need tools to help them to do this. There's a lot of variation in these image modalities, and and we didn't talk about the ethical constraints, no? There's also the privacy on the other way, but that's another problem. So thank you. Thank you. These are some of my colleagues of the lab, some students, and well, I'm available in case you have some questions, please.
Thank you so much for your conference. Doctor, we have a few questions from the Zoom meeting. Would you like to answer them? The first one is, it says, since ground truth often comes from manual annotations, how can we ensure it is reliable enough to validate algorithms that might eventually outperform human experts?
That's a very good question. Thank you. Thank you very much to the person that asked. It's very hard. Usually you need more than one person to do this annotation, so they all agree in statistically, no, for the ground truth. But that's what is desirable. No, we don't always have that, but but that's what we are expecting for that. And there are now some models that I tackle, trying to surpass that problem with deep learning models that try to surpass that problem, like doing some processing that doesn't need that many annotations.
The next question says, how is the challenge of anatomical variability across patients addressed, and in which organs or body parts do you think this challenge is the most significant?
Again, please, I said again.
How is the challenge of anatomical variability across patients, and in which organs or body parts is this challenge most significant?
Very good question. It's significant. It happens in all the body. Like, I am for Mexicans, I am a tall person, but there are some others that are shorter, and some others that have more weight, and others that are slimmer, for example. So everyone, there's a variation of these anatomical organs inside also, and so that's a problem, no? And it happens in all your body. It happens in all your body. That thing.
I think it kind of leads to another question that says, if a person has a deformity, how does the medical image segmentation system ensure that it is correctly identified that the individual is healthy in case they actually are? If a person has a deformity, how does the medical image segmentation system ensure that it correctly identifies the individual as healthy in case they actually are?
That's a good question. And deformities is something that has to be with shapes, no? I'm going to tackle in that way, with shapes. So if, let's say, for example, that I usually have 5 fingers in your hand, and suddenly there's a person that only has 4 fingers, even though it's a deformity, it doesn't say that it's sick, no? But then we need if you want to find where is that deformity, then you need to incorporate in the algorithm something that defines shapes in advance, no? That says normally 5 fingers is what everyone uses, everyone has, no? But it suddenly comes, like at the active shapes model, that I remember I said that it has a specific form, like the butterfly, for the midbrain. So if it doesn't have that shape, it would never, it won't get a good segmentation from that.
Okay, and the next question says, validation includes only to have good metrics for our segmentation, or do we need to do a clinical trial to implement it in diagnosis?
You are trying to set this into a medical environment. We need to have, it's very important to have the clinical people, the clinicians next to you. Very
Experts.
important, yeah, expert for that. Because they are going to be the ones that use these tools, no? So they
But
have,
it needs to be supervised, of
yeah,
course.
it needs to be supervised. Most of our projects usually have a clinical supervision.
Okay, and the last question would be, UNet architecture can segment any element as nuclei or detect tumor and stroma, and how can we use data augmentation?
First of all, data augmentation is used in all deep learning area. Data augmentation is to have from one image, let's say, obtain maybe 9 more, no? That's through some image processing or image processing algorithms. I'm gonna get variations of the same image. That's data augmentation. And we need that if we want to use deep learning. It's something so common that there's functions for that already program when you are trying to get to use deep learning. And then what was the second part?
It was the same question. Okay. Thank you so much. I think it was a very interesting lecture to see how experts in engineering and medical doctors are coming together to have these kind of results. Thank you so much. Please, an applause again for Dr. Jimena.